Moving on to the third section of our lecture, it is about monoclonal gammopathy. Monoclonal gammopathy, also known as paraproteinemia, is the presence of excessive amounts of myeloma proteins or monoclonal gamma globulins in the blood. It is usually due to an underlying lymphoproliferative disorder or hematological malignancy, for example, multiple myeloma. It is closely related to plasma cell dyscrasias, and the most common condition of monoclonal gammopathy is MGUS, also known as monoclonal gammopathy of undetermined significance. In this section, we will talk about the differential diagnosis of monoclonal gammopathy, what is monoclonal gammopathy of undetermined significance, and how it is related to multiple myeloma. There are certain types of paraproteinemias which are basically divided on the basis of the monoclonal protein found in the blood. They are of particularly three types. One is the light chain, the heavy chain, and the whole immunoglobulins. These paraproteinemias, there are certain other diseases which are also related to monoclonal gammopathy. These disorders include the most commonest being the monoclonal gammopathy of undetermined significance. Then there is a smoldering multiple myeloma, which is closely related to MGUS. Then we have multiple myeloma. There is light chain amyloidosis, Waldenstrom macroglobulinemia, Boehm's syndrome, plasmacytoma, and certain miscellaneous MGUS-related disorders. If we define a monoclonal gammopathy, it is a pre-malignant clonal plasma cell disorder characterized by presence of monoclonal M protein. Monoclonal M protein means only a single immunoglobulin is found. Less than 10% of clonal plasma cells in the bone marrow, and absence of multiple myeloma or related lymphoplasmacytic malignancies. Monoclonal gammopathy of undetermined significance usually presents in 3% of the general population who are more than 50 years old. The incidence of this disease increases with age. There is a higher risk and earlier age of onset in blacks. It is a requisite precursor of multiple myeloma. This means that it has a tendency of transformation into a malignant disease such as multiple myeloma, light chain amyloidosis, and Waldenstrom macroglobulinemia. The exact cause of MGUS is not known. However, it is detected years before the diagnosis of these particular lymphoplasmacytic malignancies, which include multiple myeloma, light chain amyloidosis, and certain other diseases. There are three main subtypes of monoclonal gammopathy of undetermined significance, depending on the type of immunoglobulin that is found in the blood. They are of immunoglobulin IgM type, non-IgM type, which include IgA, IgG, or in rare cases, IgD or IgE, and certain light chain subtypes, which include either kappa chain or beta chain. The risk of progression to malignant disorder depends on the type of these immunoglobulins. If a patient has immunoglobulin G or A subtype of MGUS, there is a greater tendency of progression to multiple myeloma. If a patient has an IgM subtype of MGUS. It has a tendency to progress to Waldenstrom macroglobulinemia or other lymphoproliferative disorders. And in case of light chain MGUS, there is a greater tendency of transformation into light chain multiple myeloma. How we can diagnose this monoclonal gammopathy of undetermined significance? It has a specific criteria which includes no end organ damage, monoclonal protein of less than 3 grams per dl, and clonal plasma cells of less than 10% of the bone marrow. This criteria was established by WHO, and there are certain other points besides this criteria which include there should be no evidence of B-cell proliferative disorders along with MGUS, because it is not possible for a person to have monoclonal gammopathy along with these B-cell proliferative disorders, which include multiple myeloma, Waldenstrom macroglobulinemia, and amyloidosis. No M proteins or only small amounts of monoclonal light chain are found in the urine. And when no end organ damage means there should be absence of lytic bone lesions, there should be no anemia, there should be no hypercalcemia or renal insufficiency related to M protein. So we can say that there is a rule of no that we follow in the diagnosis of MGUS. It is not a malignancy. It has no known etiology. There should be no hyperviscosity syndrome, no macroglobulinemia, no lytic bone lesions, no anemia, no hypercalcemia, or no renal insufficiency should be present in case of MGUS. How we can treat this condition? There is no definitive treatment that is necessary for MGUS. Only a periodic follow-up in order to rule out the malignant in order to detect the malignant transformation into a multiple myeloma or other malignant diseases. All patients with MGUS should have a follow-up in 6 months. If the patient is stable and there are no signs and symptoms present, we will go for the risk stratification. If the patient depicts low risk, no need for follow-up, usual medical care should be provided to the patient. In case of intermediate or higher risk patients, annual MGUS follow-up is required. The follow-up should be performed with certain tests such as complete blood count, calcium, creatinine, and serum protein electrophoresis and free light chain assay. On the other hand, if you find symptoms in a patient or there is possible progression, you should go for workup of lymphoplasmacytic malignancy. If you find a malignancy, manage it accordingly. If you do not find a malignancy, follow the criteria for the intermediate or high-risk patients. That is annual MGUS follow-up with certain important tests including the CBC, calcium, creatinine, serum protein electrophoresis, and free light chain assay. There is a greater tendency of MGUS to progress to a malignant disease known as multiple myeloma. The risk is around 1% per year, and 3 factors are responsible for helping in this malignant transformation. Those 3 factors include whenever there is M protein greater than 1.5 grams per dl, the presence of abnormal light chain ratio, and decreased 1 or 2 non-involved immunoglobulins. Any immunoglobulin which is not involved in that particular type of MGUS, if it is decreased, that is responsible for the malignant transformation. Chronic polyneuropathies are usually associated with immunoglobulin isotypes, particularly the isotype IgG, IgA, and IgM. These present with isolated sensory symptoms in distal extremities. They have electrodiagnostic features of an axonal sensory or sensory-motor polyneuropathy. Depending on the type of monoclonal gammopathy, the patient can give a variety of pictures, either presenting with axonal sensory loss, or they might have a sensory-motor combined type of picture. These neuropathies usually do not respond to immune therapies, which are designed to reduce the concentration of monoclonal protein. So if we have to treat these conditions, we need to target them in a different way. Some patients present with generalized weakness and sensory loss. In these patients, the electrodiagnostic studies are indistinguishable from CIDP without monoclonal gammopathy. Because in case of patients who have CIDP without monoclonal gammopathy, they usually present with both motor and sensory symptoms, along with the involvement of all the distal and proximal segments of a nerve fiber. Their response to immunosuppressive agents is also similar to those of the patients who have a monoclonal gammopathy. One of the exceptions is syndrome of IgM-kappa monoclonal gammopathy. The IgM-kappa variant of MGUS is an exception to all other neuropathies. This variant is associated with an indolent, long-standing, static sensory neuropathy. So, in this case, there is no motor involvement. The IgM-kappa variant is only involving the sensory component of the nerves, and it is a static neuropathy. It does not progress. Patients usually present with tremor and sensory ataxia. It mostly involves males and patients who are older than 50 years of age. So we can say that this disease occurs in middle to old age. Monoclonal IgM immunoglobulin. It binds to normal peripheral nerve constituents. Myelin-associated glycoprotein. It is found in the paranodal regions of Schwann cells in these patients. The binding appears to be specific for a polysaccharide epitope that is found in other normal peripheral nerve myelin glycoproteins such as myelin protein 0 and myelin protein P22. And it is also found in some normal nerve-related glycosphingolipids. So these anti-MAG neuropathies, these are particularly important because they have a sensory, they present with sensory findings such as sensory ataxia and tremors, and they have a characteristic electrophysiological pattern. In the MAG positive cases, myelin-associated glycoprotein positive cases, the IgM paraprotein. So now we're talking about the IgM variant. It is incorporated into myelin sheaths of the affected patients. When this IgM paraprotein, it incorporates into the myelin sheaths, it results in the widening of the spaces between myelin lamella. This produces a distinctive ultrastructural pattern. As you can see in this diagram, there is spacing of myelin lamella giving us an ultrastructural pattern. this diagram over here, this shows us the biologic transition from normal plasma cells to multiple myeloma precursor disease. The precursor disease includes MGUS, monoclonal gammopathy of undetermined significance, and smoldering multiple myeloma. These are both the precursor disease to multiple myeloma. It consists of many overlapping oncogenic events. Now, this biologic transition is consisting of mostly oncogenic events that are responsible for their conversion. These events do not all occur in each affected individual. For example, hyperdiploidy over here, it is present in approximately 50% of the patients of precursor and multiple myeloma tumors. Now, once an oncogenic event occurs, it almost always persists. It cannot be undone. The two major types of events include IgH translocations, and there is a hyperdiploidy. A unifying early event in the most precursor and multiple myeloma tumors is the dysregulation of cyclin D gene. Now, this is a unifying oncogenic event that is found in both the precursor disease and in the multiple myeloma. Activating mutations of NRAS and KRAS, they are each present in about 15% of multiple myeloma tumors. So in case of multiple myeloma, we find both these mutations. However, NRAS mutations are present in precursor disease or in MGUS tumors, but KRAS mutations are absent in these tumors. So this is one of the differentiating point between multiple myeloma and precursor disease, that precursor disease lacks the KRAS mutation which is present in multiple myeloma. Now, constitutive activation of the nuclear factor kappa B. This nuclear factor kappa B pathway is mediated by mutations in some tumors during the progression. Other events such as like the RB gene inactivation or deletion of the P53 and P18 genes, they are mostly seen at the level of intramedullary or extramedullary multiple myelomas. So these mutations are only found in the advanced cases of multiple myeloma, not in the precursor disease or the earlier stages of multiple myeloma. Through the stage of intramedullary multiple myeloma, the tumor cells are strongly dependent on bone marrow microenvironment J. The reciprocal interaction of bone marrow microenvironment and tumor cells, it results in changes in the bone marrow microenvironment, which are these changes in the bone marrow microenvironment are responsible for the lytic lesions that are characteristic of multiple myeloma. So let me repeat this. The reciprocal interaction of bone marrow microenvironment and tumor cells, it results in changes in bone marrow microenvironment, and these changes are responsible for the lytic lesions which are the characteristic of multiple myeloma. What are those changes in bone marrow microenvironment? They include osteoclast activation, osteoblast inhibition. These are the normal bone metabolism is maintained by the activation of both these cells, which are the osteoblasts and osteoclasts. Both are responsible for maintaining the normal metabolism of bone. But in case of multiple myeloma, when there are changes in the bone marrow microenvironment, it leads to activation of osteoclasts and inhibition of the osteoblasts. There is increased angiogenesis, that is increased new blood vessels formation, an altered expression of cytokines, growth factors, and adhesion molecules. Due to this altered expression, they start damaging the bone marrow microenvironment, leading to this to the lytic lesions of multiple myeloma. Extramedullary tumors, they have developed features that make them independent of this bone marrow microenvironment. Now, monoclonal gammopathy has certain hallmarks, which are the demyelination and remyelination. Axonal loss in these cases develops over time, and in anti-MAG polyneuropathies, they are usually refractory to immunotherapy. In small proportion of patients, 30% at around 10 years, MGUS has a tendency to evolve into malignant conditions such as multiple myeloma or lymphoma. This is a defining criteria for MGUS and related disorders such as smoldering multiple myeloma and multiple myeloma. The non-IgM variant of MGUS, or for the other variants of MGUS, all these three criteria must be met. The serum monoclonal protein should be less than 3 grams per dl. The clonal bone marrow plasma cells should be less than 10%. An absence of end organ damage such as CRAB that can be attributed to PCPD. In case of smoldering multiple myeloma, serum monoclonal protein IgG or IgA should be more than 3 grams per dl, or clonal bone marrow plasma cells should be more than 10%. So in MGUS, they are less than 3 and less than 10, but in smoldering multiple myeloma, they are greater than 3 and greater than 10. An absence of end organ damage such as CRAB that can be attributed. However, in case of multiple myeloma, all two criteria must be met except as noted. There should be clonal bone marrow plasma cells more than 10%, presence of serum or urinary monoclonal protein except in patients with true non-secretory multiple myeloma. There should be evidence of end organ damage that can be attributed to the underlying PCPD, plasma cell dyscrasia. That includes hypercalcemia, the serum calcium greater or estimated creatinine clearance. The serum calcium should be more than 11 milligrams per dl, or the creatinine clearance should be less than 40 ml per minute. Anemia should be present, which will be normochromic normocytic with hemoglobin of more than 2 grams per dl below lower limit of normal, or hemoglobin 10 grams per dl. And bone lesions such as lytic lesions or severe osteopenia attributed to a plasma cell dyscrasia or pathologic fractures need to be present in order for the definitive diagnosis of multiple myeloma. Multiple myeloma is a plasma cell dyscrasia that is characterized by bone marrow infiltration by monoclonal plasma cells and the presence of monoclonal immunoglobulins in the serum. It is the second most common hematological malignancy. Symptoms are defined by the presence of myeloma-defining events such as anemia, renal impairment, hypercalcemia, or bone lesions. Approximately 85% of the patients present with osteopenia at diagnosis. Bone metabolism that is normally maintained by the activity of the osteoclast, by the balance between the bone formation and bone resorption, which is mainly regulated by the osteoblasts and osteoclasts, is impaired in case of multiple myeloma. Myeloma cells secrete several factors that inhibit the activity of osteoblasts. and they activate the osteoclastic activity, leading to the resorption of bone. And the bone marrow microenvironment plays a role in the expansion of tumor. Now, the clinically overt polyneuropathy that occur in 5% of the patients with typical cases of multiple myeloma. They exhibit lytic or diffuse osteoporotic bone lesions. These neuropathies are sensorimotor in nature, and they are mild and slowly progressive, but some of them can be aggressive and recurrent. They may be severe, and most of these neuropathies do not reverse with successful suppression of myeloma. They persist even after the suppression of myeloma. In order to diagnose, there are certain electrodiagnostic and pathological features which are consistent with the process of axonal degeneration. And in myeloma with osteosclerotic features, as commonly as 3%, there is association with polyneuropathy in more than one half of the cases of multiple myeloma. Multiple myeloma, the neuropathies which may also occur with the solitary plasmacytoma, they are distinct because they are demyelinating in nature and they resemble CIDP. They often respond to radiation therapy or removal of the primary lesion. They are associated with different monoclonal proteins and light chains, lambda in most of the cases, and they are typically refractory to standard treatment of CIDP. These neuropathies occur in association with certain other systemic findings, which are basically the findings of Poems syndrome. These findings include thickening of skin, hyperpigmentation, hypertrichosis, organomegaly, endocrinopathy, anasarca, and clubbing of fingers. So, the patient with these neuropathies can present with these signs and symptoms of Poems syndrome. The levels of vascular endothelial growth factor are increased in serum in case of multiple myeloma, and this growth factor is somehow felt to be responsible for the pathogenesis of this disease. If we talk about the treatment of multiple myeloma, the treatment of neuropathies associated with multiple myeloma are best directed at osteosclerotic myeloma cases. These treatment options include surgery. We can treat them by performing a surgery. They can be managed radiotherapeutically. Chemotherapy is another option. And there is another option known as autologous peripheral blood stem cell transplantation. So these are all the options that are available for the patients of neuropathy presenting with a multiple myeloma. This was all about the third section. Stay with us for the final section. Keep watching SCADE.com.